Evening to all. This session, we have speaker, 8 speaker, but some are not coming due to visa issue, and 2 are not coming for visa issue, and others are present. And WHO head, Dr. Ivo Kosur will present her paper with his own paper, combinedly. Yeah. Okay? I will tell. So, let me call upon Dr. Ivo Kosur, CEO, International Council of Ophthalmology. He will speak on ICO's role in enhancing excellence in eye care. And Dr. Alarcos' topic, update from WHO, key eye care initiative and product. Okay.
Good afternoon. So we had a little bit sad news that we are missing 2 speakers, but I have also positive news that will definitely be appreciated. We have, as part of my presentation, and my great pleasure and honor to introduce my former colleague, Dr. Alarcos Cieza, who is currently based in Geneva at the WHO. She could not travel because of other commitments, but she sent us a very nice recording, so it will be all part of the presentation. So let me just start with saying we are all united in our pursuit of excellence in eye care. And I would like that we agree on that we have some theme, that the presentations and the knowledge that will be shared this afternoon has a glue to connect all the components which are about outreach, which are about human resources, but also about the absolute latest artificial intelligence. So it nicely all brings together the latest and the cutting edge in our field. Because we have a speaker from WHO, I would like to introduce also where WHO fits in this. WHO has members. Members are member states represented by ministries of health. ICO, International Council of Ophthalmology, is in official relations with WHO as the only ophthalmology society or association, I should say. And while WHO is more in the political cloud and setting the scene for what needs to be done globally in healthcare, we are more in service delivery, working with individual societies of ophthalmology. So this is about combination or partnership in public health and in eye care provision. As I said, WHO is a specialized agency of the United Nations. The HQ is based in Geneva. They have 6 regional offices. One of them is in this city, in New Delhi, for Southeast Asia. And some of us in the room belong to that one, while the others belong to Manila. For instance, Japan, where the regional office is based there for Western Pacific. As it happens, ICO is also based in Switzerland, in Geneva, and our members are national, international subspecialty regional societies of ophthalmology. Now, as Alarcos will talk about the current agenda at the WHO for eye care, I would just like to remind those who may not be familiar with how WHO works. It has 194 member states, 6 regional offices, and they all meet annually at the World Health Assembly. The HQ is in Geneva, and the way the big meetings are organized is that there is executive board of WHO and then World Health Assembly, and that's the really big gathering of ministers of health. And at those gatherings, I dare to speak about these things because I spent 20 years leading the eye care program before moving to ICO. We had every other year since 2003, every other or third year, we had a resolution on eye care. And that is really very unique because to have that attention from all countries around, and they vote on that, right? So it's not something to take lightly. So just to give you a perspective how these gatherings look like in WHO when the World Health Assembly is on in full swing. And now, why do we have that organization? Because currently, you know, you look at CNN, you hear all those concerns, funding, right, and constraints. Well, we do need global health organizations because they not only provide leadership and convene all parties to discuss important matters and also emergencies in global health, but they also stimulate and coordinate research. They are very busy with norms and standards, and I would put there also the international classification of disease. I think this is, if we don't know anything about WHO, as even starting doctors, we know the thick book, the International Classification of Disease. So this all is happening there, and when I was there, we were contributing to that on iHealth. Then they are very busy with policy development. They also provide technical support. This is very important. Shall we say in a given country, Nepal, they would like to set up a national program. They would like to assess eye care services. They would like to have a specific developed program for diabetic retinopathy, for ROP. They can call on WHO and say, can you help us to get experts? Can you send us an expert group? And it does happen. I was part of this for many times. And they monitor. They collect data so that we know the, you know, you name it, in all spectrum of health indicators, including eye health. This is what is happening there. There's a history of resolutions and action plans, and also we should know that we have a very strong presence at the United Nations. We are very privileged to have a resolution on eye health adopted by United Nations a couple of years ago. So with that intro for our guest speaker from Geneva, I would like to introduce Dr. Alarcos Cieza, who is unit head of WHO sensory functions, disability, and rehabilitation. And now you think, where is eye health? So eye care, eye health is under sensory functions because we have also hearing impairment and hearing health. I was at a certain point in time in charge of both. So hearing and vision is under sensory functions. So now we will enjoy
Greetings to this 40th Asia Pacific Academy of Ophthalmology Congress. From a public health perspective, there is a clear need for concerted action for eye care for two key reasons. Firstly, population coverage of the most cost-effective eye care interventions is low. There remains an estimated 800 million people who do not have access to a simple pair of spectacles, and close to 100 million who have a vision impairment due to an operated cataract. Secondly, the demand for eye care services will increase in the coming years due to our aging populations and lifestyle. We don't have to look far to see a clear example of this. The rates of childhood myopia are rising significantly in Southeast Asia, largely driven by lifestyle-related risk factors. New strategies are needed, and WHO is pleased to see that eye care has gained significant momentum on the global health agenda over the last 5 years. A demonstration of it is the adoption of the World Health Assembly and the United Nations General Assembly resolutions on vision and integrated people-centered eye care, and also the endorsement of the 2 global eye care targets for 2030 has been a significant milestone. These targets request a 30 percentage point increase in effective coverage of cataract surgery and 40 percentage point increase in effective coverage of refractive errors by 2030. Now is an important time to translate these global strategies and targets into country action. WHO is working together with key stakeholders in the eye care sector and beyond. WHO has also undertaken a number of actions over the last couple of years to support countries to strengthen eye care in their health systems. Some of these key actions include collaboration with over 300 experts to develop the Eye Care in Health Systems Guide for Action, and many of you were involved in it. And also a range of other technical tools that provide practical, step-by-step support to countries in planning, implementing, and monitoring eye care services. Important to mention today is the specific action plan for integrated people-centered eye care in Southeast Asia 2022-2030, developed and launched in 2022. In May 2024, WHO also launched a SPECS 2030 initiative to support countries to sustainably increase coverage of refractive error services. Since the launch, the initiative has gained significant momentum. WHO has leveraged its strong convening power to first establish the WHO SPECS network with over 40 member organizations to ensure coordinated advocacy and united action on refractive error. Secondly, WHO brought together key private sector actors to seek meaningful contribution towards this agenda. And most importantly, there has been a strong country demand with over 15 countries now committing to country-level SPECS 2030 initiatives in this year, 2025. WHO is committed to continue to further drive these eye care initiatives forward in countries. However, of course, we cannot do this alone. Addressing the huge unmet need for eye care will only be possible through a strong collaboration and coordination among all eye care professionals. Thank you to all of you for your continued commitment to improving eye care globally. I wish you a very productive and successful Congress. Thank you.
Wonderful. So, Dr. Alarcos, we worked together for a couple of years. She specialized in rehabilitation and disability. But as part of the unit there, also eye care and hearing care is there. Just that you understand, she's not an ophthalmologist, all right? But she does a lot for us. She's originally from Spain. Now, what she referred to is a long history of resources and political agenda in WHO supporting prevention of blindness. She also referred to some, shall we say, tools and resources published by WHO with strong engagement of national societies as we are here in this room, including ICO. And also she referred to SPECS 2030, which is a dedicated initiative to address the unmet need regarding spectacles, correction, refractive errors. So all that is, of course, available on ICO website, on WHO website. Will not go in any detail. I just wanted to somehow summarize what she talked about, and now how do we use all this. So when you look at those tools and resources, it spans from human resource development to data collection, monitoring, assessment of eye care services, including the World Report on Vision. So I would really like to invite you to explore those documents because they are extremely helpful. The resolutions are political, shall we say, substance we can use when we advocate for resources, when we go to our hospital directors, to our ministries of health, because ministers sit in those big rooms, the slides I showed earlier, and vote on those resolutions. So our minister says, yes, eye care is good. He or she comes back home, and we say, how can we help you so that we can accomplish something? So please use it for advocacy and for promoting our field of medicine. Now, as I said very briefly, ICO is more in supporting eye care provision, clinical part, and also knowledge sharing. We have over 180 society members. WHO was established or founded in 1948. We started in 1927. So they will be 80, we will be 100 very soon. So just a reminder, with, of course, all the respect and gratitude goes to the previous generations, but we are trying our best that they don't feel disappointed. Now, what are the core areas of work? Well, it's definitely advocacy and all that what we spoke about it. I would like to point out probably three, just very briefly. Examinations, very popular around the world. There's a series of them, 4, and after completing the final one gets the, becomes the fellow of the International Council of Ophthalmology, FICO. They are here also on the website. You can get all the information. Fellowships, we are really very grateful to our collaborators, partners, also donors, that we can still continue with this program. Many wonderful stories are coming back. You know, every single person, it's a story. It's a life-changing experience. Thank you very much to those who host our fellows, and thank you for all the collaboration to support our junior ophthalmologists. Finally, we have a newsletter and social media. We have around 100,000 subscribed recipients. So, of course, it's our great pleasure to promote our members' activities, our partner activities. You will see on the website prominent place, APAO, and All India Society of Ophthalmology meeting now. And as it happens, we also have our meeting, which is our, in the sense of all of us, as we are all in one family, ICO family, and the next one is coming next year in 2026 to Prague, Czech Republic. There was a top-class stellar meeting in 2014 in Tokyo, and again my gratitude goes to Professor Tetsuro Oshika, who is one of our prominent speakers also in the room, for convening this wonderful gathering. I don't know if we can ever meet that accomplishment, but we are really trying hard not to disappoint. So we will be there. The meeting goes around regions. It goes, shall we start from Americas, then goes to Europe, Middle East, Africa, and shall we say Asia Pacific. So we have 4 regions in ICO, and the meeting goes around, and for each region there is a selection process of the venue. So after 26 it goes to Middle East Africa, and in 2030 it goes to Asia Western Pacific. So with my invitation, of course, to be again together there, I would conclude this presentation. Thank you very much.
Thank you, Dr. Ivo Kosur, for your nice presentation, both the presentation. So you just call.
Yeah. Okay.
is ready.
So it's my great pleasure now, thank you very much, and my great pleasure to invite Professor Tetsuo Oshika from Japan, President of the Japanese Ophthalmological Society, who will change the subject from public health and WHO to very hot topic, which is revolutionizing ophthalmology, digital innovation, and artificial intelligence. Thank you.
Thank you for the invitation. After the blanket lecture by my previous speakers, I will go a little bit more specific topics. It doesn't work. Could you push the button? Oh, okay, it's working. Okay, here's my financial disclosure. We are facing a global shortage of ophthalmologists, healthcare providers in ophthalmology. One end is we have more demand, growing demand. Other end is we have fewer supply of ophthalmologists. There are many factors, so I don't have enough time to explain each factor, but we have challenging situations. And how to address these issues? The ideal is to develop human resources, but it takes time and huge budget, so it is not a feasible option. So what we can do right now is maximize the use of available technologies, IoT, digital technology, and AI. So today I'm going to talk about two topics. The first one is about the usage of AI in eye care. In medicine or in ophthalmology, there are many areas where AI is already being used. In Japanese ophthalmology, we have established Japanese Society for AI in ophthalmology 4 or 5 years ago, and we are doing a very active things. The first, we developed AI-assisted diagnostic tool for retinal diseases. We targeted 11 retinal diseases, and we have a very accurate accuracy of this application. It works very simple. When we put the retinal photo, the AI application immediately answers what's the highest probability of this image. And this technology was applied to the anterior segment. We have worked on the AI-assisted diagnosis application of the corneal diseases, focusing on 11 diseases like this. So when we compare the accuracy of this application with the resident or anterior segment specialist, the AI produces a higher accuracy. This is based on only the appearance of the cornea. So how it works? We put the image on this into this software. It replies the most probable diagnosis. If there is two combined diseases, they reply two diseases like infection and maybe a scar or something like that. And one of the unique features of software is that when it indicates the infection, this application goes to the next step. It says what is the pathogen. Most likely pathogen is bacteria, fungus, or acanthamoeba, or virus. This is two-stage diagnosis tool. This is an example, so I'm going to skip it. And the next application is tumors. Tumor is very kind of a demanding area where there are not many specialists, including myself. I'm not a specialist. So in this study, we tested our application to differentiate carcinoma and carcinoma, and AI application gave a highest accuracy. It's only because of the appearance. Of course, if we do some pathology test, it is different, but only based on the appearance, AI was most clever. So next step, we analyzed the ability of this software on 17 tumors. So this is a kind of preliminary result, but it was really good. It may be too good, the accuracy was. It depends on the type of the tumor, but it's very promising. So we are now working on this kind of application tool. The AI detect the region of the tumor first. After detecting the region, it will provide the possible diagnosis. Currently, we are working on to apply this technology to the smartphone devices. The latest version of the smartphone is very wise. It can take pictures of the anterior segment without no attachment. Only smartphone can take this kind of photo of the anterior segment. So what we are thinking is that after taking the photo using the smartphone, we may do some triage decision trees, like this is urgent or not urgent or no consultation is needed. So this is going to be a future application of this smartphone technology. Another area which we are working right now is application of technology to the more wider devices. One of the examples is automated refractometry. This maybe refractometer or calorimeter is ubiquitous. Many examination room has this device internationally or globally. So if we can use these images taken by these devices for the AI technology, this is going to be a huge market, I guess. Another area is estimation of visual field measurement, estimation from the OCT data. So visual field examination is demanding. Patient education is needed. Man sources is needed. Of course, you need a machine and budget and time. So if you use the OCT measurement is very simple, straightforward. So we can estimate the visual field based on the OCT measurement in the early glaucoma, moderate glaucoma, a very good guess, get good estimation, advanced glaucoma or combined glaucoma and diabetic macular edema. So I think that this is going to be a very huge application, a future in the market, in the future. So AI in the ophthalmic surgery is going to be a big area, but because of the time limitation, I'm going to skip everything. But I believe that we can use AI technology to analyze what is a good surgery, what is a bad surgery, and how apply this to the education of the training, written training. The second area is imaging technology, because we have a lot of imaging in ophthalmology, but some of them are not very clear. So there is a technology in the industry which can sharpen the image simultaneously without any delay, like this one. So processed image, after processing, you can obtain a very clear and bright images. So here is one example. On the left-hand side, you see one retinal tear, but on the right-hand side, you see another retinal tear more clearly. When angiography is processed, you see much more abundant information on the right-hand side. Smartphone photo of the ROP retinopathy, it makes a difference. You see more information after processing. In the small pupil photography, you see much more clearly on the retina, anterior segments, yes, and OCT images. You see a vitreous herniation on the right-hand side. So in conclusion, image sharpening technology can enhance even poor quality images from basic devices. So it can improve the standard of care and contribute to the prevention of blindness. Thank you very much for your attention.
Thank you very much. It was a fantastic talk. Are there any questions? Not at this, yeah, there's one coming. He could talk.
Yeah, that's the only suggestion. Just give us a suggestion of the diagnosis. The final diagnosis have to be done by the doctors.
Okay, thank you. Any more questions? At this stage, we can always discuss after the session, of course. There will be time. So it's my great honor and pleasure to invite our esteemed guest, Professor Ava Hossain, chair and of this session, but even more importantly, president of APAO. And Professor Ava will speak about strategies and activities in preventing blindness in Bangladesh by 2030. And that nicely set the scene, because it's not only technologies, it's not only clinical provision of eye care, but it's also planning for the future, right, what we need to have in place so that we are ready. Thank you.
Okay, thank you so much. Yes, there is no financial. This is the socio-demography of Bangladesh, and population is 170 million. 170 million population in Bangladesh. National Eye Care, that is Director General of Health Service, Ministry of Health and Population Control, they make the survey in 2020, nationwide blindness survey. Not working? Please help. It's not working. Okay. And after that National Blindness Survey, it was detected that untreated cataract was 70%. 70% untreated cataract, and rest are the 30% different type of diseases. So the magnitude of blindness, in 2000, there was a survey, and after that, in 2020, after 20 years difference, there is a survey. So prevalence of blindness in 2000, it was 1.5%, and in 2020, it has reduced to 0.77%. Number of blind, 650,100, and 532,985 was the number of blind. You can think that this is not that much reduced, but as population increases every day, and within this time, the blindness also increases. That is why the number is much more. And cataract backlog, 17,400 and 389,614 in 2020. So the magnitude of visual impairment and causes of visual impairment, that is, in mild cases of visual impairment, cataract was 47%, and refractive error 42%. This is the mild visual impairment, and moderate visual impairment, that is cataract, goes to 76%, and refractive error 15%, and the rest are optic atrophy, complicated cataract, myopic degeneration, all this. In case of severe visual impairment, it was cataract 81%, and refractive error 9%, and others are minimum. So 5 in every 100 adults, that is aged was 30 years and above, they are suffering from mild to severe degree of visual impairment. An estimated of 1.4 million people are living with mild to severe visual impairment in Bangladesh. So cataract is the primary cause, and that is responsible in severe cases, 81% of visual impairment. So what is the prevalence of visual impairment by socio-demographic characteristic? It was illiterate group, lowest income group, and not working group. These are the highest priority. So the National Eye Care Program, Ministry of Health and Family Welfare, they have a mission to reduce avoidable blindness by developing high quality, cost-effective eye care system in underserved area of Bangladesh. So everyone, everywhere can regain or retain their sight. And the goal to integrate national eye health policies, plan and program in national health care to ensure universal eye health coverage, to prevent avoidable blindness, to give priority of cataract surgery in national plan, to ensure high quality, low cost cataract surgery to eliminate backlog. This was the goal. And this strategy and activities to reduce preventable blindness by 2030, that was done by National Eye Care Program. What that strategy was? Provide high quality, low cost cataract surgery to eliminate backlog, to improve quality and outcome of this surgery. This is the first priority. Increase cataract surgical coverage, provide accessible, affordable services to the hard-to-reach area. This area, most people are sufferer, as because they could not come and doctors are not going there. That is the way they are sufferer. Public awareness program for early detection and referral of cataract. So strengthening coordination mechanism between GO, NGO, and private sector. Expansion of maximum collaboration in service delivery through different agencies. Private sector encouraged to take more responsibility in providing low-cost services. National Eye Care, they have a program. This is very important. I would like to say to everyone that there is a demand-side financing. That means National Eye Care provide financial support for the marginalized group of people for doing cataract surgery. And this support covered transport, food, and subsidy for day loss. To give awareness, to initiative the people underserved area, so that people will have some money. With that money, they can come to the center, they can do, and for the day loss, some money will also they got. And this is the after effect. Before blind, before surgery, when he was blind, the granddaughter is taking him to the center, and after surgery, he was so happy, and you can see the picture, that one. And this is a very important thing, that he's a very well-known singer, and he, after singing, developing the awareness. That means in the song, the wording are like that. It was prepared by the National Eye Care, and they are singing in that way, so people can aware about the blindness and they can take the treatment. And this is another counseling at the sub-district level. All the women are sitting there. What is the target? High volume cataract surgery. If we can do this type of cataract surgery, then we can reduce the backlog. On an average, 15 surgery per hour per surgeon, 50 to 70 per day per surgeon, and around 200 surgery per day in each designated eye hospital. So the quality assurance of this surgery is very important. We are looking to that. Ensure to follow all the steps of standard cataract surgery protocol. And the cataract surgical rate going up till 2030, it will be 3,500. If we can do that thing, then we can reduce the cataract blindness within this period 2030. So the postoperative eye examination, that is the primary health care worker, they visit the house to house after the surgery and taking care of the patient, whether they have any type of complaint, any redness, any pain, any dimness of vision like that, then they will send them to the nearest center for the follow-up. What are the activities? There is, of course, some barrier, non-availability of the eye care services at the community level. Actually, there is no eye clinic at the community level. So people will go to the general hospital at district level. And in private level, there is very high cost of the eye care and distance of health facilities for eye care. These are the barrier of taking care. So government established some community vision center, one community vision center for every 300,000 population. Their screening and treatment was done by consultation of the ophthalmologist, a base hospital through telemedicine. And patients are referred to the base hospital for surgery. Now, 200 community vision center established, aim to develop 500 CVC by 2030. This is the base hospital. These are well-equipped surgical intervention, a team of ophthalmologists there to do the surgery. So, in conclusion, advocate for integration of eye health with continued health system strengthening process. If that can be done, then that will serve better to reduce blindness also. National budget needs to increase on the basis of socio-demographic and financial impact of blindness. Need to provide training for more ophthalmologists for doing high volume cataract surgery. Monitoring of cataract surgery outcome is essential, and national blindness survey needs to be conducted biannually, not 20 years. So to generate quality data for taking appropriate interventions. With this word, I would like to thank you all for patience hearing. Thank you.
Thank you, Professor AIOS2025. Can you hear? Yeah, thank you, Professor AIOS2025. Any questions or? Okay, if not, now I request Professor Wanicha Chunkenki, I hope I have pronounced properly, speaking on, he is the immediate past president of Royal College of Ophthalmologists of Thailand.
It's okay.
Excellent. Congratulations.
Thank you.
Excellent. We are struggling with this.
Slideshow.
So I googled the so that he knows.
Slideshow.
Yeah.
Can you
Excellent.
how can slideshow for me? No. Which one?
Is it open?
Yes. Thank you. Slideshow. Slideshow for me.
Photos. Take some photos.
Yeah.
Yes, sit on it.
It's fantastic, and you are right. We need more.
Good afternoon, Namaste. So I would like to show you the security of securing access to eye care experience in retaining ophthalmologists in the upcountry of Thailand. I have no financial interest. So my topics include why do we need to develop the Thai sustainable ophthalmologist model? And second, how do we move on? And the third one was next. The objective to improve ophthalmologist maldistribution in Thailand and to empower the ophthalmologists in the remote areas for their service and academic responsibilities to effectively support the patient's referral system. This is a commencement ceremony of Thai ophthalmologist training each year, about 47 to 80 residents. In Thailand, comparing to Poster Hangsen in Bangladesh, we have only 71 million population, and the area is about 500,000 kilometers. Our life expectancy about 77 years old, and we have doctor and nurse, and including midwife, about 4 per 1,000 population. Mainly of our health workforce are in public sectors, and also 30% health resources made in private sector. We have 100% of universal health coverage in 2002. And cost of ophthalmologist maldistribution in Thailand, we can show that because of low population of doctor and population ratio and inappropriate funding support and training facilities, also inadequate academic mentorship in remote hospitals and specialized eye centers. Many young ophthalmologists prematurely end their professional commitments than expected due to their clinical workload imbalance. So in Thailand, the ratio of eye doctor population very unsatisfied yet, but mostly maldistribution occur in northeastern part of Thailand. You can see our the figures. It show that in Bangkok, which is a capital city, we have almost 1,000 ophthalmologists, while in northeastern part of Thailand, we have only 230 ophthalmologists. And all of ophthalmologists are in public hospitals. Public hospitals, we have, there are almost 1,000 hospitals, and private almost 400 hospitals. Also medical school, around 30 hospitals. And those ophthalmologists are
produced are developed in medical schools. And that's why we have to raise the new project on collaboration with our partners between health service system and health education system. For health service system, you can see, for health service system from the picture, you can see Thailand, we have health service system around 13 regions under Minister of Public Health, and also 11 training center. 8 are in Bangkok or capital city, and only 3 are in other provinces, in northern part of Thailand, in adjacent part of Thailand, and also in northeastern part of Thailand. So this is a new project in our country. Even though we have 8 healthcare education center, healthcare education center, but those have responsibility to train all residency program in all parts of Thailand. So this is to encounter with maldistribution of ophthalmologists in Thailand. And this project we start from 2019, which is the year of pandemic. You can see the blue stand, it's the apply candidate, and for the orange one is that they accepted. You can see that from 2019 until 2024, the accepted of residency from other part of Bangkok is increasing. And also the residency training program, we developed the new program, which is developed according to new curriculum for residency training based on postgraduate medical education or WFME global standards for quality improvement in 2015. After 2019, the COVID attacked the world, and also in Bangkok, in Thailand also, we have the training program that accommodate with the pandemic during that time. So we have the project for online learning, knowledge assessment, and also we follow those residents who graduate from those years after the pandemic to follow if they have any skills that can cover with their eye care in the community, and we found that it's very good after we developed this eye training program online. Also, we have funding support for those research and education for residency. This is very important. True success is not the learning, but in application to the benefit of mankind. Put self-interest as second, put public interest as first priority, then your life will be good. This is our Prince Maidon motto. He is the father of modern medicine and public health in Thailand. So we teach our students to follow his motto. And also his granddaughter also follow his motto. And we have Prince Maidon Award each year, and 2 Prince Maidon Award from Eye Center. One from Professor Dr. Napoleon Ferrara from American ophthalmologist from University of California, San Diego, for his discovery of vascular endothelial growth factor, VEGF, which plays a significant role in cancer treatment. And the second one, just 2007, we got Professor Root. You know Professor Root. He restored his eyesight of the millions of cataract patients in poor countries through safe, effective, and environmental in economy surgery. And that's why we have the campaign for a large charity eye surgery project for underprivileged Nepalese patients from Thai government to serve those to get brightness to Nepalese eyes. And also we have Prince Maidon Youth Program to develop our 6-year medical students to study in eye field. And we have right now, we have 4 medical students, 6-year medical students who develop their project on eye care. And right now they are the fellow at different university. This is one of my fellow. She learned in Department of Optometry, Stanford University, for her attenuation of immune response to subretinal processes. And right now it's developing. And also we have a very good model who got the Sasakawa Health Prize. He's Professor Paisan Vibunsuk. He is a retinal specialist. And also we have the very good campaign on Good Eyes for Thai Kids project to give the spectacles to those students who staying in remote areas, and we can get rid of this refractive error in children for many cases. In conclusion, I would like to summarize that to achieve long-term sustainability for distribution of ophthalmologists to ensure that all Thai people reach equitable and accessible primary eye care. First, satellite standard residency training programs, including special projects and appropriate trainee selection process. Second, financial and non-financial incentives increased allowance by the government. And third, leverage tele-ophthalmology, and as Professor Okichi has already mentioned, and mobile service to improve referral networks, and also to train their mindset on to be a role model by a royal family, to earn, learn, and then return to the community. Thank you so much. And this Run for Eyes in APAO 2019 in Bangkok. I am a half marathon runner, so I run every year. Thank you.
Thank you very much for your excellent presentation. Any question? No. May I call upon Professor Ki-Ho Park? He will speak on normal tension glaucoma, evidence-based risk factor and treatment strategies. Very good.
Thank you, Chairman. These are my disclosures. So, by definition, normal tension glaucoma is a common form of POAG in which there is no measured elevation of the intraocular pressure, which means there can be unmeasured IOP elevation. NTG is an optic neuropathy characterized by optic disc excavation and corresponding visual field loss in the setting of open anterior chamber angle and statistically normal intraocular pressure. So the statistical intraocular pressure may differ between different ethnicities. In epidemiology, Japanese, Korean, Chinese, Singapore, mostly they have 80 to 90% of OAG are normal tension glaucoma. However, in Western, about 1/3 of OAG are normal tension glaucoma. In India, maybe between Western and Asian people. So these are known risk factors. I'm not going to talk all of them, but because of time, intraocular pressure, disc hemorrhage, myopia, hypertension, hypotension, and ocular perfusion pressure will be shared with you. So intraocular pressure, in Tajimi study from Japan, it's population-based study. Intraocular pressure, myopia, and age are the risk factors of NTG, POAG, but 92% of those OAG were NTG. In Korean National Health and Nutrition Examination Survey, similar result came out. Older age, higher IOP, myopia were the risk factors, and in addition to that, male gender, hypertension, non-overweight status were the risk factors. 95% of OAG were NTG in this study. In another NAMIL study, population-based study, non-glaucomatous eyes IOP was 13.3 plus minus 2.7, which means 2 standard deviation is less than 19 millimeters of mercury. So it's quite different from Western. And in NTG, the IOP was slightly higher, 14.6 millimeters of mercury, which means intraocular pressure is still a risk factor in NTG. And if we measure the intraocular pressure in different position in asymmetric eyes of NTG, quite interesting finding was in sitting IOP, it was similar in both eyes, but in supine, worse eye showed a higher IOP. And if the patient lying down in the lateral position, worse eye dependent IOP was even higher. And in healthy eyes, if the eyeball is compressed against the pillow, the IOP elevates from about 13 from sitting to up to 19 or 20 when the eyeball was compressed against the pillow. So sleeping like this position will be very bad for the normal tension glaucoma patients. And if we measure the pressure with the contact lens sensor, and if we measure their body posture and the blood pressure continuously for day one like this, and the other day opposite eye, what we found was that the standard deviation, which means short-term IOP fluctuation, is higher in normal tension glaucoma compared to the healthy eyes. And during sleep time, the intraocular pressure was higher in NTG. And evidence of IOP lowering treatment in NTG was shown by CNTGS and EMGT. However, in CNTGS, beta blockers were not used, adrenergic agonists were not used, and prostaglandin were not available at the time of the study. And EMGT, they used the laser plus betaxolol. So at present, we are using prostaglandin analog as a first choice, and followed by brimonidine. Logit study support this result. And recently, rho kinase inhibitor, it can increase the trabecular meshwork outflow, so it can be another candidate, and followed by topical carbonyl anhydrase inhibitor and so on. What is disc hemorrhage? It is even higher in NTG compared to POAG. And if we follow those patients longer, more than 5 years, the detection rate is even higher in NTG. About half of the NTG has disc hemorrhage compared to about quarter of the POAG showed hemorrhages. And disc hemorrhage and IOP reduction less than 20% was the risk factor for RNFL progression. And disc hemorrhage positive eyes shows higher percentage of lamina cribrosa defect compared to the disc hemorrhage negative eyes. Myopia has shown as a risk factor in Tajimi study and also in Korean National Health Nutrition Examination Survey. And vascular abnormality has shown as a risk factor of glaucoma, normal tension glaucoma in Hong Kong study. Silent cerebral infarct was the risk factor. And also in our Korean population, small vessel disease was shown in the eyes with RNFL defects. What about systemic hypertension or hypotension? Large epidemiologic study has support hypertension is a risk factor. And also our study also supported. And nocturnal blood pressure dip, over dipper was very high in normal tension glaucoma compared to the high tension glaucoma. So blood pressure, low blood pressure and high blood pressure is a risk factor of glaucoma. So it has U-shaped risk curve. And lower systolic ocular perfusion pressure and lower systolic blood pressure was shown as a risk factor of progression in EMGT study. And also in a Japan study, disc hemorrhage, long-term IOP fluctuation, and greater vertical CD ratio was shown as an NTG progression. And also in CNTGS study, risk factor for normal tension glaucoma progression was disc hemorrhage and migraine. So in summary, risk factors of NTG and treatment strategies are including IOP, disc hemorrhage, myopia. All of them, we are still lowering pressure to treat NTG. What about vascular factors? So gold standard is IOP lowering. And in addition to IOP lowering strategies, several alternative therapeutic approaches have been proposed involving vasoactive, antioxidant, anti-inflammatory, and or neuroprotective agents. However, unfortunately, to date, there are no standardized or proven alternative treatment for NTG when compared to traditional IOP reduction therapies. Thank you for your attention.
Next speaker is Professor Sundaram Natarajan. He will speak on screening to surgery to manage diabetic retinopathy.
Yeah, thank you. So my title is, can I have the slides? So the road to diabetic blind-free world. So the diabetes is now the epidemic of the 21st century, and it's the major cause of blindness in the working middle-aged adult population and the 5th cause of blindness globally. So the IDF Atlas 2021 says approximately 537 million adults are living with diabetes, and the total number of people living with diabetes is projected to rise to 643 million by 2030 and 783 million by 2045. So this is at a glance you can see, which is the diabetes data from 2000 to the year 2045. And this is a new study published in Lancet Diabetes and Endocrinology in volume 11. The new study published in Lancet estimates that 101 million people in India are living with diabetes. This is in 2025. And you saw the previous statistics, which is projected as 79 million, is now 101 million. And 11.4% of India's population are living with diabetes. A survey commissioned by Health Ministry also found that 136 million people living with pre-diabetes, that means 15.3% of country's population could be living with pre-diabetes. So conventionally, retinopathy screening is done by fundus examination by ophthalmologists using conventional fundus by trained eye technicians or optometrists. And the primary issue in India, we have one ophthalmologist per 100,000 population. And the problem faced in our health system, 70% of Indian population resides in rural area or urban slums. And there is low awareness or ignorance about the diabetes and diabetic complication which can produce blindness, and follow-ups required for years together in a patient with diabetes and eye problem. And the technical difficulties we face is unreliable internet coverage, deficit in supply of electricity in many areas, shortage of trained medical staff for operating conventional fundus cameras, and portability of conventional fundus camera. And these issues can be solved using computer machine learning or the AI for analysis of retinal images in people with diabetes, thus solving at least some part of the problem, which was published by a group from the Delhi in 2019. And intelligence is the capacity to analyze, think, make a decision, and categorize. And AI involves formulating a specially made algorithm according to our needs to develop this capacity and include it in an electronic device like smartphones. And that's what the India has done through the company called Remedio. And I don't have any financial interest. And the role of AI is the integration of retinal photography and AI-based reading and diagnosis system performs the following procedure automatically: identifies fundus features, classifies image quality, classifies the existence and severity of disease, and based on deep learning technology. So the plan of action, we screen, diagnose, and treat them. So we need more working hands, and we have to make use of the minimally trained staff already available, and we arm them with AI to bridge this gap. So we make a pre-camp awareness, assembly of the diabetic patients, capturing of the images, and diagnosis by AI. So we did a preliminary study by Aditya Jyot Eye Hospital and Kamala Sundaram Foundation, earlier known as the Aditya Jyot Foundation for Twinkling Little Eyes, which we have published as a first of its kind world project for the screening of diabetic retinopathy, use of semi-skilled health worker. That means we develop a person who can operate a smartphone, and India has 1 million smartphone users, and deploy AI in the smartphone and using a non-mid-radiative camera in the municipal dispensary in Mumbai. The Remedio is a company in Mumbai, which is, in Bangalore, India, South India. The computer is trained to accept retina pictures properly taken by the trained semi-skilled worker compared with thousands of previously provided DR pictures, and based on that notify the staff. That means only a mobile is required, which patient needs to be referred to an ophthalmologist labeled as referable diabetic retinopathy. This is a iPhone 5, 6, 7, 8 model, which is fixed to an infrared device where both can be charged. So you don't need electricity, you don't need internet. It can be mounted on a suitable bike for transporting for screening purpose and can be mounted on any table like a slit lamp. So either you can use a handheld, which I generally don't like because the examiner and the patient may not be steady to get a good photograph. So I suggest to use a chin rest for the patient and the slit lamp attachment, so that both the observer and the photographer and the patient is stable. We also used another company called Forus, which they made a replica of the retina photograph, which is about $4,000, and which is made in India and again in Bangalore. It's called the Forus Trinetra fundus, which we carried in the motorbike, and we can serve anywhere, which is also has AI now. And you can see my late father, who was an ophthalmologist, and my grandmother, who inaugurated this in 2014. So I use this using anybody can screen for diabetic retinopathy, and the acronym I use ABCD, so that we don't need education. We don't need an educated person, not a technician, nor an optometrist, an ophthalmologist to do screening. So we have a lot of people. We have 1.45 billion people here, and we have 645,000 villages where we need people like this to do the screening, and that's my dream. So we have this image capture by a non-specialist, analysis of images, and the sensitivity we can do. And this is what we did, capturing a fundus photo with a smartphone. You can see, you can assemble the diabetic patients and get it done. And you can see this is the video which shows the mobile phone. We can anybody can take a photograph like this. They need about 2 to 3 weeks training, and we are trying to make a certified program. So you apply that on the AI, as you see here, the tick mark, and the AI will say that the 99% confident. That means the photograph is good. And the blue thing, what you see, is the one which identifies the color changes in the diabetic retinopathy, and then based on the images in the mobile itself, it will say referable diabetic retinopathy or not. As you see, the blue area which is analyzed by the AI. And this is what we are training, and now this company has come out with a software to diagnose even glaucoma and also ARMD with the same image. And this is a photograph on fundus on phone, and a comparison with Zeiss photograph, which says I think the quality is almost equal, even though it's not the same. And this is the example where you see the blue color, which is an area which is analyzed by the AI with any of this classification, and then the person who's doing it need not know anything. And when the person comes to the area with Wi-Fi, all the images can be captured in the computer in a PC, and then analysis can be done. It can be stored, and it can be used for follow-ups years to come. So only people who need retinopathy, who has retinopathy, will come to the center for treatment, not others. So this will be the link between medically underserved area and tertiary healthcare services. So I made a program as the president of All India Ophthalmic Society in 2019 called the Stop Blindness. The acronym is for Screening through Teleophthalmology for Prevention of Diabetic Blindness. And on 26 January 2019, we did this in the biggest slum of Mumbai, which is the largest slum and one of the largest in Asia, where we came in the Guinness record of screening 649 diabetic patients in 8 hours. 53 were having retinopathy, and they were treated free. And this is the certificate we got for the Guinness record. The idea is to create a record, but not for so that we want somebody to do this more and do it more. And this was the publication, The Diagnostic Accuracy of Community-Based Diabetic Retinopathy Screening with an Offline AI System on a Smartphone. And we also published with more data in the Indian Journal of Ophthalmology. And the idea is that it's 100% sensitive. We work with the diabetologist, endocrinologist, and other comorbidities associated with. So the research question we asked is AI reliable to pick out those in need for seeing an ophthalmologist, and it was 100% specific, sensitive, and 88.5% responsible specificity. So reliability for AI screening for DR in need of ophthalmic checkup by an eye doctor is 100%, and which was confirmed. So the advantages of using AI and a non-skilled worker trained only to do a retinal photograph and make them a semi-skilled. The advantages is early referral of the referable diabetic retinopathy and greater awareness about diabetes, its effects and importance of regular follow-up, greater chair time to the ophthalmologist, timely medical surgical intervention to prevent complete loss of vision, and more job opportunities for more working hands and skill development of the less educated. And this is what is the experiment I'm doing with the Mumbai slums. Hope to expand to the villages of India, and once this is successful, I would like to extend to the South America and entire Africa. So we can make the world free of the burden of diabetic blindness, and teleophthalmology can show us the way eye care can reach every village via teleophthalmology and AI. So AI, this is what Stephen Hawking said, AI is likely to be the best or the worst thing to happen to humanity. It is up to us which one it's going to be. I think it's for us as an ophthalmologist to use AI, and we should not be a slave to the AI, but AI should be our slave and use under us, and so that we can get only the treatable patients, so that we spend time on treatment, and the prevention and the other things can be done by the rest of the people who are not ophthalmologists, including this will help to make a policy by the health government also. Thank you very much.
Are there any questions at this stage?
Yes. Yes. Pardon? There is a base for yes. Is not the smartphone is taking the no, no. Smartphone is attached with an adapter with the infrared device. So what is the cost of that? It's no. It they are making an app. So that app you need that app, the adapter, and the infrared device. In Indian rupees, it's 4,50,000, which is 450,000 rupees, which is around $4,000.
Any other questions at this point? Of course, we can. Is there a question or?
Is there a question, Ganga?
No, no question. Right. We can use the time
so
we have.
Dr. Raju, yeah. So Dr. Raju is our past president of All India Ophthalmic Society and also president of past president of Indian Medical Association. Microphone is not on. Yes.
Yeah. So congratulations, Dr. Natarajan, for the excellent presentation, which was very comprehensive, and you detailed all the practical ways of how to deal with the increasing incidence of diabetic blindness, how we should reach to the far-off places, the rural areas, and we were always partners in our efforts too. And I don't know, Dr. Awa Hussain described about the methodology they adopted in Bangladesh, where it is mostly government-sponsored. Am I right? Or
Yes.
you have an ophthalmic society in Bangladesh.
Yes.
Do that society have any program or a project aimed at ameliorating the increasing incidence of cataract blindness in Bangladesh? They are curable ones, the cataract. This one is a preventable one. So that difference we need to understand.
Yes.
Yes.
Cataract society do the cataract surgery. That is the eye camp. Eye camp. That's all. Yeah, okay.
What? Yeah.
Actually, I was one of the members of this blindness survey that was done.
As a task force and in Bangladesh. Yeah.
That's the government program.
Yeah, that's right. That's what she said.
Yes.
But there are many other organizations also
Private and
preventive part of
NGO.
Yeah, private concerns, no.
NGO.
Institutions.
Bangladesh have their own hospital.
Yeah,
We call it OSB.
OSB.
right.
They do the screening outreach program and bring the patients to their hospitals and do the cataract surgery. And mostly free of cost.
Okay,
So that's the big work is done by the organization.
okay, that's good information.
Right. Thank you.
I have a comment about the previous presentation on the normal tension glaucoma. And that's a difficult situation to diagnose because of many reasons. I just want to ask the presenter, how do we fix, because the tension is already in the normal range. How do you calculate or modify your formula to fix the target IOP in such cases? Because the tension is already low. So you cannot apply the nomogram of the normal POAG patients, how we fix that target pressure for that patient. So how do we fix the target pressure for the...
Okay, thank you for your question. In CNTGS, they recommend 30% IOP reduction from the baseline, and EMGT, they request 25%. But in our actual experience, about 25%, between 20 to 25% IOP reduction from baseline is significantly slowing down the progression of glaucoma in our cases.
Did your study also consider the thin corneas? Or most of the cases are sometimes associated with, and also myopia. You mentioned about myopia.
Yeah.
So do these factors interfere with our diagnosis? Because the evaluation or the field defects might not be as good or may not conform to the normal glaucomatous pattern, especially in people with myopia and high myopia. So how do we make a diagnosis of, sometimes it's difficult in a myopia.
It's very, very difficult in myopia guys because the optic nerve head is quite strange shaped. So in those cases, we measure the peripapillary retina RNFL thickness, and also we measure the macular area GCIPL thickness, and also we look at the retinal nerve fiber layer defect by photography or OCT.
When all said and done, it's a difficult situation.
Yeah, it's quite difficult.
We have to be very
and
careful.
AI can help us as well.
Okay, thank you.
Thank you.
Thank you. Any more questions at this point? If not, it brings us to the end of the session. Thank you very much. Thank you, of course, to our speakers, and I would ask for the final words, Professor Ava, to close the session.
Thank you very much, and thank you very much for so many questions. But I would like to say one thing. I didn't say only the government part, only the survey that has taken under the leadership of the government. But I have said also in the strategy that there will be the strengthening of the GO, NGO, and private sector. That is very important, as because private sector are always for the blindness, prevention of blindness, they are working together with the government. And that is why I have declared in that way. Thank you so much. And I'm thanking to all the speakers, to Professor Kehoe Park, Professor Tetsuro Oshika, Professor next I would not pronounce, better not to do any commit. So you are nicely, so nicely and so elaborately explained. It is really, I think everybody, and house full. I'm really happy to see that one after another is coming. How many coming, I am counting. That is very good looking. So that is another point that everybody said, and the audience, for the audience it will be okay. And thank you all the participants, as because everything, if speaker good, if chairperson good, that not at all the factor. Factor is the participating person, the audience. If you are not here, no value. So it's the value depend on you, and you have asked question, that is also the success. So thank you so very much. And I am so thankful to Professor Ivo Kosur and Dr. Natarajan. I call him Noto, naughty boy. So that is also, he is very kind enough to conclude, give me the chance to conclude so that I can talk something. Thank you so very much. Now we will run to our opening ceremony. And before that, we'll
We'll
take
have a group
photograph.
photograph.
The speakers,
with all the speakers.
Yeah,
Yes,
the faculty.
right.
Thank you. Thank you so much. Wonderful, wonderful. We take the photo all
Okay.
together. Yeah.
Where do you want to collect the comments? I loved your presentation. I need your presentation, and particularly the quote by the prince. I hope I can have it in the mail. Okay, come. I'll give you my camera. I'll give it to you. No, Ganga is taking one. I'll send it to you. Okay, you want in this camera too. Come. Yes, okay. Yeah, I'll send it. I already sent you the other photograph. Yes. 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 Whose camera is that? Yeah, okay. You okay? You got it? Okay, great. So I'd like to have your